providers and really understood it better after I left and started to help other counties across the state understand it better. So I'm really looking forward to get you guys hyped up, revved up about CalAIM and see what the opportunities are there for you in your prevention work. And I'm going to turn it over to Gretchen.
Thanks, Beljeet. Hi, everybody. Gretchen Schroeder. I'm really excited to see so many familiar faces and names. So looking forward to our training today. I'm a CalAIM consultant with CFPIC, and I do like all the words that are put in here. Most are negative, but we're going to try to get some more positives going. But I do appreciate folks who are excited about this or find promise with this. Hopefully we can illuminate some more positive pieces. I've been working in CalAIM since its launch, and prior to that, whole person care. And a few of you I recognize from my days doing the Medi-Cal Administrative Activities program, MA. So lovely to see you all again. Yeah, we're excited to be here.
Great, thank you, Gretchen. And I'm going to kick it off. I'm going to go through a number of the slides and then kick it back to Gretchen. We are looking for this not only to present our slides and the content, but also for this to be a discussion. And we do want you to ask questions as they come up. So either raise your hand and we'll get to you, or you can definitely put the question in the chat, and either Gretchen or I will try and answer the question in the chat, or maybe we'll stop and answer the question live. I kind of, I don't like to just read off the slide, and so I give you time to read the slide and then provide additional content to the slide. Again, there's about 60 plus slides, I think, here. We've done this. Gretchen and I have been working together on CalAIM now. I want to say it's been about a year, maybe longer. I can't remember. And we have a flow to this, and sometimes we get through the slides in the time allotted, and sometimes we don't, and that's okay. You can definitely, and I think I have my contact information at the end. If you want more information, you want technical assistance, we can definitely help with that, and you can reach out to me via email. All right, so we're going to explore today through this session the possibilities of aligning the prevention work that's happening across the state, how, the landscape is changing there for prevention, really trying to get to children, youth, and families faster in that upstream, and how that work can align with CalAIM, either as you coming on as a provider of these services and benefits, or as a referral source for children, youth, and families that you serve. And how can you become a referral source to fit it into that community pathway that I know a lot of counties are looking to implement? How do we get to these children, youth, and families before they come into child welfare, right? How do you get to them in the community before someone calls it in to the hotline? And also on the juvenile probation side, how do we get to those children and youth that may be coming up into juvenile probation, again, before they need to intervene, so that we get them in that upstream process? Next slide, please. So our goal today, again, is to really help you understand two critical areas of CalAIM, which is enhanced care management. I saw in the comments a lot of people mentioned ECM, and then community support. So we're going to go into that now. Because of time, it's not going to be a really deep dive. Again, we can definitely provide more of that technical assistance if you are looking to come on as a provider. And then how does it align with the prevention work? I'm going to talk a little bit about, the levels of prevention and secondary versus tertiary. Where could this help with some of that? And ultimately, the goal here is to help you understand that if you leverage this, it could help either prevent children and youth from coming into care, or it could potentially help with families and reducing maltreatment, so that if they were involved in your system, you've then referred them to a partner in your community, and hopefully they don't need to come back and be involved in your system again. Next slide. So we're going to look at this from, that whole child, youth, and family, and looking at the whole picture here, and how do these benefits and services come into what you typically do, and look, and it's potentially it's a new revenue source for a lot of providers. It's a new entity that you're now having to engage with through the managed care plans. A lot of the providers that are coming onto this space are probably providers that you already know or have worked with, or at least that is the expectation of the state DHCS, is that the managed care plans are bringing on providers who have experience and expertise with these particular populations of focus, and we're going to go into that a little bit more. Next. So this is our agenda. The slides are based on this agenda, and we are going to talk about how to operationalize this, and also some of the funding opportunities. Gretchen is going to go over that, and then some of the things that are happening in 2025 this year, because this is part of a waiver, and the waiver is over December 31st, 2026. And so the state is continue to roll out some things and standardize some things. So Gretchen is going to go over that. All right, let's talk about it. So we have about 15 million folks in California on Medi-Cal. And the most important thing that I want to highlight here is that, one, you're probably already working with some of those populations, right? A lot of our children, youth, and families that are coming to the attention of child welfare or juvenile probation, or maybe your CBOs, are on Medi-Cal. So in order to qualify for the benefits and services under CalAIM, one, the person has to be enrolled in and eligible for Medi-Cal. And then the second piece to this is that they have to be enrolled in a managed care plan. And each county has plans, and so you're either a one plan county, and there's two types there. You're either a single plan county, or you're a county organized health system, which typically only has one plan, or you could be a multi-plan county, which could be two or more. We have 2 counties in the state that have 4 plans that that are offered to Medi-Cal members. And so that's important to know as well, especially if you're serving a particular county or counties, what plans are available for Medi-Cal members. Now, in some counties, and it's mostly in the single plan and the coast counties, members are automatically enrolled in a plan. However, in the counties where Kaiser is also a option, the member may get to decide. Now, in the multi-plan counties, the member has to decide themselves, or at least have a conversation with an appropriate authorized person about what plan they want to be in. And so part of this as professionals in this space is understanding what the plans are being offered in your county, and then if a Medi-Cal member is automatically or selects a plan as well. The other thing I want to mention with the plans is there, in some of the counties, there is still an option to be on fee for service, or what I used to know as straight Medi-Cal. The important thing to know about that is if a Medi-Cal member is on fee for service or straight Medi-Cal, they are not eligible to receive the benefits that we're going to talk about today. These benefits are only being provided through the managed care plans. All right, so you have on the screen here what it's about. I just want to add to this is that it can be seen as part of the work that you are trying to accomplish with Family First Prevention Services, and to reach families, children, youth as they are upstream, and that they're that their identified needs are not at a high intense level yet. And so it aligns with secondary levels of prevention, and the goal of the secondary level is to alleviate identified problems and prevent escalation. But it also can align with the tertiary level of prevention, where the goal is to prevent reoccurrence of maltreatment that could lead to re-entry into foster care. So later we're going to walk through a scenario, and I will talk a little bit more about that. Now, the scenario is really focused on how to refer families before they get to that involvement with child welfare, but I will highlight, some of the things that you can do if they are involved and still refer to these benefits and services. Next. So there are 11 initiatives as part of CalAIM, and the ones that we're going to focus on today here are the ones highlighted in blue. So we're going to spend time talking about enhanced care management, community supports, and then Gretchen's going to go over some of the funding opportunities under the incentive payment program and the path, providing access and transforming health. Is quite a bit that's being offered through that as well. Again, it's all about building capacity across the state in every local community so that we have enough providers to meet the needs of the Medi-Cal members that will need these services. Now, initially, when the state was starting to roll this out, they had said that 3 to 5% of your members on Medi-Cal are seen as the highest risk, most vulnerable, and that's what ECM is supposed to target. Community supports is for any member on Medi-Cal, and I think they might have come down in that percentage a little bit, and maybe you're seeing it more at the maybe 2 to 3%, but it is really trying, ECM is really trying to target the highest risk, most vulnerable, which we know is the children, youth, and families that all of you are working with. All right, why does CalAIM matter? So just like your prevention work can't be done in silos, that as a community you have to come together to work together. This is the goal for the state with CalAIM. And so they are recognizing that in order for CalAIM to work, it needs to be provided by locally based community providers, CBOs. Now, they are also looking for county departments to come on as providers as well. But I think as we think about this in the prevention landscape, as counties are moving towards community-based providers for their prevention work, we can also align CalAIM and really lift up community-based organizations to also come on as providers for CalAIM as well, so that your highest need families that do need more than maybe at that tertiary level, that really crisis level, that's what your child welfare departments and your juvenile departments are working with, those children, youth, and families. And so other families can really be served by your community-based organizations. Now, in addition to that, a big piece of this is that the providers are locally based, culturally appropriate, trauma informed, and again have experience and expertise to work with these populations of focus. And definitely, the experience and expertise is important when working with populations that may typically come to the attention of child welfare or juvenile probation. This is a unique population that we work with, and so making sure that we have providers that know how to work with this population. Next, whole child perspective. So just like other initiatives and things that are happening across the state, like we've listed here, there is a lot going on across the state to really lift up how we need to continue to better serve children, youth, and families, and how to serve them in environments or touch points that already exist, like through the school system. So a lot of work is happening there to provide better access to mental health services. And then what else is happening in the child welfare and juvenile probation landscape through the AB 2083 work that all of you are involved in. And so this aligns, CalAIM can align with that. And a lot of the counties at the county departments, they are starting to look at how do you bring in this new entity of the managed care plan and its providers into that system of care work. And it, in my opinion, it fits very nicely into that, not only working with your at-risk populations, but your current populations involved in your systems. And so there's a lot of work and discussion happening across the state about how do you bring in the managed care plans to those conversations as well. All right, just want to give a moment to see if anyone has any questions. I know Gretchen answered the question in the chat, but just want to kind of open it up to see if anyone else has a question. You can definitely raise your hand. Not seeing anyone. All right, we're going to talk about enhanced care management. Like I mentioned in my introduction, that this was what the managed care plans talked a lot about when I was still at the county and trying to work on implementation, not only in the agency I was with, but what would it look like countywide. And at that point, this was 2020, 2021. And the goal at that time was just build your provider base. And so all they ever wanted to talk about was ECM and community supports. But it was also because there wasn't a lot of guidance and direction about the other initiatives and other things that were part of CalAIM. So we're going to kind of talk a little bit about that to help you understand better what ECM is really trying to do. So ECM is a whole person interdisciplinary approach to care that addresses the clinical and non-clinical needs of members with the most complex medical and social needs. ECM provides systematic coordination of services and comprehensive care management that is community-based, interdisciplinary, high-touch, and person-centered. This ECM builds on both the design and the learning from the whole person care pilots that a lot of counties participated in and Health Homes program. ECM with community supports has replaced both of those initiatives, and it's scaling up interventions to form a statewide care management approach that is a key component of a population health management program that we're going to touch on a little bit. And that's a huge part of this. And that when I understood what population health management and that whole program was, I better understood CalAIM and I better understood what it was trying to do. And I think it's one of the things that managed care plans initially didn't frame well, because for me as a county person at that time, I needed to understand the big picture here. Like, what are we trying to achieve here? And basically what we're trying to achieve here is if you screen folks faster, you assess them and then get them the services that they need, hopefully you're going to be able to reduce the escalation of higher needs later. And so population health management is really trying to look at this Medi-Cal population and really address what they need when they come on to Medi-Cal. And ECM is one of those care management continuums, and we're going to show you what that looks like in the next slide. So this is the continuum, and this is population health management, I would say, in a nutshell. And basically under population health management, the program as part of CalAIM, ECM is one of the components, as you see here on the screen, and that it's seen as the highest level of care management that a managed care plan could provide, where it's for your highest risk, most vulnerable populations. And the great thing about how the state kind of envisioned this and rolled it out is they identified populations of focus that are seen as your highest risk and most vulnerable, and that would be eligible for ECM1. We're going to go over those. Then your lower risk populations may have other needs, and so they would be eligible for complex care management. And then everyone that's on Medi-Cal would also receive this basic population health management, which is seen as like they would be offered health promotion opportunities, and you know, their health needs are at a very low level. So again, once I understood this better, I understood what CalAIM was really trying to achieve and kind of understood the big picture here. So ECM core services. This slide kind of gives you examples of what some of those services would be, but just real quick, there are 7 core services that are provided to members who are referred to ECM and then opt into it. And so the first core service is outreach and engagement. So providers that provide ECM services have to do outreach and actually engage the member and get them to sign up to this. This isn't you refer them and then they automatically get enrolled. The member has to agree to these services. After they agree, then the provider will do a comprehensive assessment and care management plan, and also provide an enhanced coordination of care. And so that means that they need to know who else is working with this member, who else is involved from a system level perspective, is child welfare, is juvenile probation, and really look at, you know, who's providing what and where still there might be some gaps and needs that are not being addressed by all these professionals, and how could they assist in meeting those needs. Other things that they would provide are health promotion and other services and benefits that the member may need, and referring them to those. Transitional care services. So that was on that one screen that showed ECM, complex care management, and basic population health. There was a column on the side that talked about transitional care. One of the things that was also added to the CalAIM slew of services and a responsibility on the managed care plan was that when you have members that come in and out of particular facilities like hospitals, skilled nursing facilities, psychiatric facilities, there needs to be better coordination of that transition and discharge. And so it could be transition back home, it could be transition to another facility. And so the managed care plans are responsible to provide that coordination and transition discharge planning. And in situations where the member is already enrolled in an ECM program with a provider, that responsibility then gets shifted over to that ECM provider. Makes sense. How many professionals do you want to continue to you know, add to the array of professionals already working with that member? And I would say in child welfare, that's something that I always wondered about. How many professionals do we need to be part of the team to work with the child, youth, and family? And so it's kind of eliminating that additional person that isn't necessary if ECM is already involved. The other 2 things that the ECM provider will also continue to work on is helping to build that member and family supports. I mean, that's big in child welfare, that's big in juvenile probation. You know, how do you build that natural support so that we can come out and that natural support team continues to work with the family as they go through the ups and downs of life, right? Today we're in a crisis, tomorrow it gets resolved, and maybe in a month or so we go through another crisis. You turn to your natural supports to help you. And then, like I already mentioned, you know, that coordination and continual referral of not only services and benefits that the managed care plan could provide or has to offer, but what else do they need in the community to help them. ECM is a year-long benefit. And then it can be authorized for an additional 6 months through the managed care plan. And if that is something that the ECM provider would take care of. So who's eligible for ECM? So these are the populations of focus, like I mentioned, these are ones that DHCS really, took time to think about and lift up, as these are our most vulnerable and highest risk populations that are on Medi-Cal. And here you'll see number 8 is the child and youth involved in child welfare. And that includes our juvenile probationers, who are considered foster youth as well. So it's not just child welfare and the child welfare department, but it's also our juvenile probation population that's also considered placement youth. Now, like I mentioned before, and when you look at the policy guide, ECM is a benefit that can be used prior to child welfare involvement. You don't have to qualify a child, youth, or family under just number 8. They may qualify under one of the others. And a lot of times we find that they qualify for more than just one population of focus. So if you're working with a family through your community pathways approach, they've never had any child welfare involvement, do they qualify under the homeless category? Do they qualify under the serious mental health? Right. So I really want to highlight that you don't have to have an actual child welfare involvement to qualify the children, youth, and families. And I think that's a big part of our change in the prevention landscape, is we're trying to prevent people from being involved in that system. And so want to highlight that they can qualify under a different population of focus as well. And we'll get into this a little bit more when we go through this scenario. So if you are interested, maybe we've perked an interest in becoming a provider for those of you that are CBOs here, and maybe child welfare departments. What does it take, right? So again, the expectation here is, and this is coming out from DHCS. They are the lead state entity on CalAIM. They then are shifting the implementation, the rollout, the vetting on providers to those Medi-Cal managed care plans, who then are responsible to build capacity in every county for every single one of those populations of focus. And so the expectation of the state is that first, it needs to be a community-based entity. It needs to be someone hopefully locally based, right? And we know CBOs cover more than one county, cover more than one community. And so if you are a CBO that is in more than one county, and it's different managed care plans in each of those counties, you would have to come on as a provider for each of those managed care plans. They're looking for providers that have experience and expertise with that particular population of focus. So if someone chooses child welfare, they've got to show that they have experience working with that population of focus. Like it says on the slide, culturally appropriate and timely, and with particular populations of focus, there may be even more things that they need to show experience and expertise, like for our populations, and I would say for all populations, but definitely that trauma informed, right? So these are additional things, and the managed care plans would work with a provider to help them through that process if you choose to go through that. All right. How do you refer? How do you next slide, I'm sorry. How does a member come on to ECM? So the state is really looking for this to be more of an organic process, though through our Medi-Cal aid codes, managed care plans could kind of go through their database and figure out who needs it through their screening and assessment process that they are responsible for. They could identify who is at highest risk and most vulnerable, but the state really wants these referrals to come organically, either from the member themselves and they can self-refer, or from folks that know the members. So it could be family and friends. It could be professionals that have worked with them, like yourself, or are currently worked with them. And so they really want it to be an organic process, because Once a referral is sent to a provider, again, remember, they have to do that outreach and engagement. And if the member has never heard of them, didn't even know that they were being referred for this service, and with all the amount of scams and all of that that's happening, when you have a random person calling your phone and you don't know the number, do you pick it up? I don't pick it up. So again, if it's coming organically and someone is referring, the hope is that you have spoken to this person and said and explained this benefit and let them know that you're going to make a referral. Are they in agreement with it? And then, help them to understand the process so that when that call, that outreach happens, the member is more likely to sign up for it.
LG, we have a question in the chat. Can hotline referrals, but EVOs or closed investigations qualify as CWS involvement?
And what is EVOs? Is that
evaluated out if
Oh,
child welfare
okay.
gets a referral, but it's not
Yep.
investigated.
Correct.
Yeah. Right. Okay. So what I would suggest is you can definitely pick the child welfare population of focus, but also see if they qualify under another population of focus. Because in the event that the managed care plans ask, though, what I've heard is that they're not asking for a lot of information to determine if they qualify or not. If it's coming from child welfare, what we've heard is they're probably going to pick up that population of focus that you selected. But I would say if they also are dealing with any of the other populations of focus, check that as well. It not only identifies that maybe child welfare is involved or has been involved, but they also have these other needs. And so it quickly provides that picture of what this person or family is dealing with. So if it's homelessness, check that population of focus. If it's a behavioral health and it's that serious mental health or drug, SUD, check that one. So again, it lets that provider know that we're dealing with someone who has complex issues that they're trying to deal with. And then better align that referral with the appropriate provider, because a provider can also come on as a provider for multiple populations of focus, so that better matching of that member ultimately. Right. Let's see, we'll go on to the next one. Any questions about ECM? Just a real quick overview, again, high level, not really doing a deep dive on this. And I think at the end of the slides, we do offer the CFPIC webpage where we have a lot of previous webinars that Gretchen and I have done on CalAIM, ECM, community supports, where you can definitely go and watch those webinars and get a deeper dive. And then, like I mentioned in the beginning, we're very open to providing additional technical assistance. And so you can reach out to both of us on that if needed. All right, next slide. So we're going to talk about community supports here real quick. Next slide. So community supports are services that help address members' health-related social needs, help them live healthier lives, and avoid higher, costlier levels of care. So these include support to secure and maintain housing, access maybe to medically tailored meals, and then there's actually now 15 different community supports. And Gretchen, I believe, is going to talk about the latest one that was just approved in December 2024. That really looked at we need to offer more than what we're offering, and that housing is, as we know, is a huge issue in the state, and folks need help with paying rent, and so that is the latest one that was added. Now, these again are provided by the managed care plans, and each managed care plan in each county that they serve get to decide which of the 14 they are going to offer. The 15th one is a little bit different. And again, Gretchen is going to walk us through that one. But the 14th, and then we have put in the chat which ones are being offered in your county. Now, majority of the 14 are being offered in each county by each plan. There are a couple that I think they've struggled to find providers to come on. And so if you see like sobering centers aren't being offered, I think another one was maybe that asthma remediation. They have struggled to find providers. But all the housing related ones, especially the first 3 here on the list, are being provided. And so you can find that in that link that we shared in the chat. So these are the pre-approved, medically appropriate and cost-effective community supports that managed care plans, again, are strongly encouraged. And they let the state know which ones they're going to offer every 6 months. So this list gets updated every 6 months, and they have to wait 6 months before they can change which ones they are going to offer in that particular county. Now, one thing to highlight here is that you do not have to be a population of focus under ECM to qualify for the community supports. Any member on Medi-Cal that's enrolled in a managed care plan can get a community support if that's needed. And so it's not that you need both. Now, if a member is on ECM, one of the roles of that ECM provider is to assess for community supports. And when you look at the ECM policy guide, you will see in there as they describe each population of focus. They also, and I really like the policy guide for ECM, though, you know, it's one of those that needs to continue to be updated and improved because everything can be improved. It lists out what outreach and engagement would look like for each population of focus. It lists out what care plan, you know, what are the components of that? And then it also kind of highlights for this population of focus, these are the community supports that we think are well aligned with that ECM population of focus. So good information in the policy guide if, you know, on a Friday night you have nothing to do and I want to do some state reading. All right, so we're going to quickly go through the next couple of slides, and these are the 14 community supports. Again, Gretchen is going to talk about the last one here on the slide here, transitional rent, in more detail because it's a little bit more nuanced than some of these other ones. So these are the housing services community supports, and we try to lift up in this slide to kind of call out our non-minor dependent and our exiting foster youth as well. And then there is money attached to some of these community support. So for example, the housing deposits comes with, I think we've heard up to $5,000. Now that does not pay for the ongoing rent. And that's where the 15th community support came in to meet that need. That obviously was an issue. The next community supports, these are additional ones. And again, asthma remediation comes with up to $7,500 to utilize to help better improve a person that has been diagnosed with asthma. One of the things, there is a policy guide for the community supports. Highly recommend that you read that to really get a better understanding of each of these community supports and what's required in order to qualify for it, but also what's the documentation that might be needed in order to get reimbursed for it. Now, if you're looking to come on as a provider for this, you know, that's also good information for you there as well. Now, if you're looking to refer, again, good information. And then the last group of community supports are listed here, where we are trying to better understand respite services, especially in the child welfare landscape with our foster youth. What does that mean? When I've looked at day habilitation programs, the ILP program screams out to me. It's really that peer mentoring. How do you help people live independently? And then we have personal care and homemaker services. that could be more aligned with our adult population, but we also have a lot of youth and children that are on IHSS as well. So again, these complement ECM, but they also can be paired up with other community supports. That the first three housing community supports, which is navigation, deposits, and sustaining, those usually are paired together, and so you can add some of these additional ones as well as needed. Again, these community supports are looking to kind of help keep the member at a lower risk level, and hopefully, not get them into those higher, costlier services that they may need. All right, we're going to walk through a scenario real quick here. And I'm looking at the time. I want to make sure we have plenty of time for Gretchen to go over her slides to really kind of connect how all of this is coming together and additional stuff. So we're going to talk about Sammy, and I'm going to give you a moment to read this, and I'm just going to highlight a couple of things. This is a family of 4, with Sammy being the identified child. There is little involvement with the father. Sammy has complex needs and is served by multiple systems, which includes behavioral health. We do have outbursts with physical aggression, disruptive, and at times aggressive at school. She does have an active IEP. We do have type 2 diabetes and mildly obese. And then strengths. She's creative, friendly teen who desires to manage her behavior and is remorseful after an incident, has some healthy peer relationships and a strong bond with her mother, current therapist, and teacher. So we'll go on to what some of the services that she's receiving. So she is receiving individual therapy and behavioral supports in school. She is on the wait list for a mentor. There is some quite a bit happening in the school setting and a potential for a school placement change, an educational placement change. And then her prior history with child welfare, with referrals, and then a previous case as well, though nothing currently. The family dynamics. So, mom is working 2 low-wage jobs. So income is limited and stretched. This obviously now is impacting housing and stability there. And so they've seen multiple moves, which has resulted in school changes. And currently she's, struggling to pay rent, and so is at risk of homelessness. There is DV history in the past, though currently the father does not have much of a presence in the children's lives or the family's life. And then mom does have a support network. So she has friends and relatives on her side and the father's side of the family. And she is engaged in trying to meet the needs of Sammy with her providers and treatment, and really trying to do what she can based on, some of the struggles and challenges she has herself of being the only income earner in the home and trying to keep a roof over everyone's head. So the current status, a CFT has been called by the behavioral health partners, and this is consistent with their system of care approach in that county. They are committed to supporting the family and keeping them at lowest levels of intervention, which basically is code for let's try not to get them involved in child welfare or juvenile justice. And they are, the family is on Medi-Cal, and they are enrolled in a managed care plan. So the 2 requirements to start looking at benefits under CalAIM: got to be on Medi-Cal, and you've got to be in a managed care plan. So let's walk through what this would look like in this family situation with the scenario. So the opportunities here, because child welfare is not involved at this point, the behavioral health therapist could be the referral source for this family. Or if we look at it through your community pathway prevention opportunity here, maybe the family is seeking out services with a CBO that is part of your community pathway network, and they could, as part of their assessment, determine that the family would benefit and qualify for ECM and could be a referral source as well. Now, they could also be a ECM provider if they wanted to be, and so they could be a community pathway participant, and they could also be a ECM provider. Under this scenario, because we do not have an active investigation or case, we would lift up the populations of focus as potentially the serious mental health or SUD needs, or the family would qualify under the homelessness population of focus. Now, if they did have a referral or a case or a prior case, you could also put them under the child welfare involved population of focus. And and just real quick, the criteria there is that the youth is under the age of 21 and is currently receiving foster care in California, or previously received foster care in California or another state in the last 12 months. Or they have aged out of foster care up to 26 in California or another state, or are under age 18 and receiving AAP, or eligible for it, or are a family where the member is under the age of 18 and one of the members is under the age of 18 and are receiving FM services or previously received FM services in the last 12 months. So just want to highlight that, though it's not in the scenario that their child welfare involved currently or recently, that is another population of focus that we could put them in. So how is ECM going to help this family? They're going to be, the ECM provider is going to be part of that team that's working with the family, right? The BH, the educational partners. If she gets onto that mentor program, working with them as well. So really looking at a whole person approach here. The ECM provider, remember those 7 core services that I listed when we started talking about ECM, they're going to help increase the support network. They're going to coordinate what the needs are of this child and family and refer them. They're going to look at what community supports would they qualify for and refer them to those and coordinate that. The way the state likes to explain ECM is that this provider could be that air traffic controller, kind of navigating and really looking at who's helping who and where are we still seeing service gaps and who could fit that. Is it a current provider or do we need to bring somebody else in to help? What are the community supports that this family could essentially qualify for? So definitely if we're looking at it from the homelessness lens, they're going to qualify for all of those housing related community supports that we've listed here. Now, if they move into a location that needs modifications based on any physical needs or health needs that a member may have, there's additional community supports there as well that they would qualify for. And then real quick, the last slide on this, and then I'm going to hand it over to Gretchen. Just how did ECM help? And what I'm going to really lift up here more than anything else is that my hope is that as we refer children, youth, and families to ECM, especially ECM, and then community supports as well, is that we are going to see less children coming into care, and we are going to see less re-entries of children that come out of these systems. And so ultimately we could hopefully see a reduction in those numbers. All right, I'm going to hand it over to Gretchen. Thank you.
Great. Thank you, Baljeet. All right, everybody, great questions. Keep them coming. Appreciate everybody's interest. We're going to jump into operationalizing ECM and community supports, and just want to do a quick reminder about how ECM and community supports are structured. It's really being implemented by the Medi-Cal managed care plans. And so the state contracts with the Medi-Cal managed care plans, And they have a policy guide for ECM and one for community supports. And then it's up to the managed care plans to really implement these programs, contract with providers, set rates, do oversight and monitoring. So all of that is happening with the managed care plans. So if you are a contracted provider, you'll be working with the managed care plans directly and not with the state, unless of course something terribly, happens, and then you need to work with the state. But most of the time we're seeing it all coming through the managed care plans. So a couple points I want to just highlight here. ECM is a Medi-Cal benefit, which means that when the state contracts with the Medi-Cal managed care plans, the plans are being paid an additional amount to do ECM services. Community supports are optional services, and the managed care plans are not currently being paid extra to do and implement community supports. They're considered in lieu of services. The intent is that they're actually going to be saving money for the managed care plans for the Medi-Cal program, because they're keeping folks in a lower setting, or they're keeping folks at home, or they're addressing some needs that will save money down the road. So that is important here. And then for counties, I know a lot of you are used to having the Medi-Cal programs have a local match, and for ECM community supports, there is no local match. You bill your services to the managed care plan and you receive reimbursement for those services. A couple of things to note, because some of the billing mechanisms are a little bit different than what we may be used to with other Medi-Cal programs. We do have 3 common payment methods the managed care plans are using for ECM and community supports. And of course, there is variation between counties and between managed care plans. So if you are in a county with multiple managed care plans, you may see different plans using different mechanisms for ECM. So just be aware of that. But the most common one we see for ECM is called a per member per month, I can't speak here, bundled payment, which is really saying that if I'm going to provide ECM to Baljeet, I'm going to be paid $300 by the managed care plan every month. And typically there's a requirement that I must touch or serve Baljeet 2 or 3 times during the month to get that payment. So that's how most managed care plans across the state are paying for ECM. And for some of the community supports, we do have another payment model called a fee-for-service payment model. And that's really paying you either on a per visit basis, on a time period basis. Maybe every 15 minutes you get paid a certain amount. It could be per diem. So if you are in recuperative care, for example, you're going to get a per diem rate as a provider. So those are the 2 primary payment mechanisms that we see managed care plans using. Of course, there are also some of those community supports that Baljeet went over that have dollars attached to them. And right now, most managed care plans are doing a cost-based reimbursement for those community supports that have additional dollars attached to them. So again, managed care plans are the ones that are really responsible for doing all of the work on ECM and community supports. There are some guidelines the state has set forth with how quickly the managed care plans need to pay providers. And we do know, and you probably have heard this too, that billing is a huge challenge. It's new for a lot of the ECM and community supports providers, and so claims are not always being submitted correctly or with all the information needed, which delays payment. So there's a lot of learnings going on across the state with these programs. We are seeing some of these getting worked out, so people are getting paid consistently. Currently, though, we know, every new provider has to learn the hard way how to do this, unfortunately. We don't call right now, ECM and community supports are not audited, but there is an oversight and monitoring process the state is implementing actually this year. And what that looks like is they're telling the managed care plans, here are the metrics that we want to evaluate you on for ECM and community supports, and how each managed care plan takes that to their providers looks different in each county with each managed care plan. Some have already been doing quarterly reviews of care plans, of billings. Some managed care plans are just starting that type of process as the state has implemented theirs. So that is happening. And of course, we'll learn more as time goes on around that. Another thing to be aware of with ECM and community supports is there are these things called hubs that are popping up across the state. Kaiser is using essentially a hub model. They call it a network lead entity, but having an intermediary organization do the contracting for the managed care plan with the providers. Some hubs also do some billing. Some hubs do more in terms of policies and procedures. It just depends on which hub folks are using. Not all managed care plans are allowing hubs to be used for ECM and community support. So again, we're seeing a lot of variation across the state between managed care plans, between different counties. So just be aware of that. Questions on that quick overview? Okay, let's get into what we all care about, which is the funding opportunities that these programs offer. I'm going to skip the slide. You'll have it. The big ones that I want to talk about are really the ones that are trying to increase implementation through capacity building, through infrastructure development. And the big ones for those are going to be what's called IPP funding, Incentive Payment Program. And those are dollars the state gave to the managed care plans way back in 2022 when this launched. Some managed care plans still have those dollars left to give out to providers, and some managed care plans have spent those down. So you would need to ask your managed care plan you're working with if they have any IPP dollars left. The one that is active right now is PATH. I'm going to focus on that first bullet, which is the PATH cited Capacity and Infrastructure Transition, Expansion, and Development Grant Program. And that is the state's grant program to ECM and community supports providers to really help them implement ECM or community supports or expand their services. Expand could mean serving more people. It could mean serving a new population of focus in ECM. But we're currently in the round 4 of PATH cited, and this is the last round of funding. So if you are thinking about becoming a provider or thinking about growing your program, you may want to look at PATH cited. The application closes May 2nd. And I know that Baljeet has dropped some links in the chat. The state has a really great website on PATH cited with a ton of information and slides on all of their presentations that are very helpful. So if you have questions on it, typically those slides will answer it. But PATH cited can be used to hire staff, to train staff, to pay office rent, to get a care management or billing system put in place for ECM and community supports. The key is it has to link back to ECM and community supports. And as we mentioned earlier, this is the last round. These are big dollars we're talking about. In the previous 3 rounds of PATH cited, the average award was $1.1 million. That was for a 2-year funding cycle. Round 4 is a 1-year funding cycle, but these are dollars that can really make a difference in how your organization can set up ECM and community supports or, expand. Now that you've been doing it, you know what you may need to really do this successfully and efficiently. The state has also identified some round 4 funding priorities, which includes looking at what are your communities, your counties' identified gaps for ECM and community supports. The state has also identified their gaps that they're seeing and really want to support providers who jump in there. And those are the birth equity population of focus, justice-involved populations, and transitional rent. So we'll talk a little bit more about that. And then, of course, tribal entities or other entities serving tribal members, rural counties. And I would really encourage you, if you're applying for PATH cited and you want to highlight that you're a rural community, make sure you explicitly state that in your application. Not all of the reviewers are familiar with California counties or which ones may have rural or urban pieces. So just make sure that you're explicit if you are applying as a rural community to state that. So you can see all of that here. And if you are a county, they are looking for counties to help jump into transitional rent, as well as other providers, which can include community-based organizations. We don't have a lot of information on transitional rent right now. We do know that the managed care plans can offer up to 6 months worth of rent. This will be our 15th community support. It's unique in that it will be required for the managed care plans to offer beginning January 1st of 2026. And the goal here is really to kind of have community supports tie into the Prop 1 dollars that we passed last year, which also has some housing payments available. You'll get all these slides. It's a great presentation the state did on their path cited for transitional rent. And we do expect to get more guidance from the state on transitional rent in April. So keep your eyes open for that. The last piece that I want to highlight, which is not direct funding, but actually does really help a lot of organizations, is what's called the TA Marketplace. And this is where organizations, counties can apply to receive technical assistance through this marketplace and choose a vendor they want to work with. And then the state pays that vendor or consultant directly for the work they do with you. So check it out. It's a little overwhelming at first. There's a lot of vendors on there, but it can do a lot of great work to support you with ECM and community supports. So I know I only have like 2 minutes left, so I'm going to just quickly go through this slide. I think it's really important. So one of the things that we think a lot about with counties jumping into ECM and community supports is it's not just a provider role that counties can play. It can really focus on being provider, but also a capacity builder. So looking around you and the organizations in your county who are involved, if there are some that are missing, please encourage them to become ECM or community supports providers. And then of course, there's also a referral partner. So even if you aren't that provider, but you may have populations you work with that can benefit from these services, your role to refer them into these programs is critical to having folks access these dollars, and then also have local providers receive those dollars as well. We have a lot of slides here on blending and braiding funding. If you're trying to figure out how to blend and braid ECM and community supports, we do have some more information here. Again, these are in the slides. So I think that really is all that we have time for. I'm going to save my last minute for questions. So if you have any questions, I know I went very quickly through this, but please let us know. All right, well, thank you all so much. I hope you enjoy the rest of the conference. It was great to talk with you today.
Thank you.
Thank you all for joining today. We're going to release to lunch. We will return back at 12:45 for your afternoon workshop.
Hi, I have a question if one of the presenters is able to
Of
stay
course.
back. So
Yeah,
as
go
a
ahead, Stephanie.
small nonprofit, I'm wondering, do I need to go through that TA marketplace or like what are your recommendations as first steps?
So do you want a contract to become an ECM or community supports provider?
Yes, correct. I'm currently plugged in as part of our local Santa Cruz County CPP. And we do support both with, juvenile probation as well as into the school systems. And our nonprofit is really focused on English, Spanish, and Mixteco, which is our local indigenous population.
Great.
So I think that we would be a really great trauma-informed choice as our evidence-based practice is fresh in about like 2-3 years as part of the California Clearinghouse. But I do need guidance as far as what technical assistance is currently available before I jump into some like TA marketplace.
Definitely. So I think the TA marketplace is a great thing, and it does take a little bit of time to get up and running. So you may just want to, you have to submit an application saying that you're eligible to receive the TA marketplace services. So you may just want to start that. The other thing that I would do is, have you attended your local PATH collaborative in Santa Cruz County?
Our local PATH collaborative, would that be our child and youth well-being cabinet?
So it is actually for ECM and community supports providers, and the managed care plan is there. And I know Baljeet just dropped the link in the chat. That is a really great way to find out who's involved in ECM and community supports in Santa Cruz. The managed care plans always attend, so it's a great way to interact with them. And so typically the facilitators that are paid by the state, they have virtual meetings every month, and they may have an in-person meeting once a quarter, though in Santa Cruz it may be more frequent. So that's the next step that I would encourage you to register for. And then last but not least, I actually would talk to your managed care plans. A lot of them have really great training modules that they provide to contracted providers, and they may have someone who can walk you through what their specific process is. And so you can understand what gaps may still exist for you. Does that help?
Yeah, definitely. I know I have I have been offered by a few folks who have gone through and are now in the ECM, kind of like CalAIM portal. But I'm just cognizant of like taking their labor and their time as opposed to like what formal pathway of support is already kind of like sustained or in place. And so
I would do it all.
yeah.
I think providers are really wanting this to work, and part of that is building a big provider network. And so if they're offering support, I would take advantage of it. It's a really great community of providers, especially in Santa Cruz. I know you guys have a really great community there.
Wonderful. Thank you so much, Gretchen and
Of
Baljeet.
course, good
Really
luck,
appreciated today's session. Bye.
Great, thanks for attending.